Hello and welcome you all to the social media initiative of the King Fahd Armed Forces Hospital Jeddah Structural Heart Disease Catheter-Based Therapies in 2020 virtual meeting. I'm Aditya Bharadwaj. I'm an interventional cardiologist and assistant professor of medicine at Loma Linda University, California. And I have the honor of interviewing Dr. Kimberly Skelding, interventional cardiologist at Confluence Health, associated with the University of Washington. Dr. Skelding has to her credit being the first woman interventional cardiologist to implant a TAVR valve in the United States.
I'm honored to be invited to be part of your meeting. I had the pleasure of being on site in Jeddah 2 years ago and see your beautiful country and be part of the meeting. So that was just a very wonderful experience and humbly to be invited back again. I have been involved with transcatheter aortic valve replacement since 2010. I was a principal investigator of all of the clinical trials for the core valve system. I've implanted both core valve and sapien and been very involved in transcatheter therapies for some time. It has been a wonderful addition to my career, and I'm happy to be here talking about it today.
Great. Thank you, Dr. Skelding. So let me start out by asking you about aortic stenosis and concomitant coronary artery disease. The timing of coronary revascularization in patients with severe aortic stenosis requiring TAVR, having concomitant CAD, has been a subject of debate. While there are no solid recommendations, the consensus from experts in the field initially was to go ahead and perform PCI before TAVR, as long as the risk of the procedure doesn't overweigh the benefits and it's a large proximal vessel that's involved and is causing angina to the patient. So it would be great if you could share your thoughts on this subject and what your clinical practice is.
Certainly. So first of all, I think that the rationale for treating coronary disease was really sort of pre-built into the clinical trials. And so starting out doing TAVR, for all of us in the clinical trials, we were protocol driven to do revascularization. So I think that's why it's become such a big part of practice. But over time, we've studied it and we know a little bit more now than we did certainly back in the beginning of the clinical trials. So there's a few things to remember. One is that 50% of patients who are undergoing TAVR have concomitant coronary disease. And you are absolutely right by saying that there is no definitive data for treating or leaving behind coronary disease before treating the valvular disease. And patients now that we're treating low risk, they have a much lower prevalence of coronary disease. And so it's changed a bit over practice time. But of the TAVR patients who have coronary disease, about 11% of them have left main and 50% have proximal LAD disease. So it's really significant. But you need to also remember that the evaluation for coronary disease early on was a little subjective. Very rarely was QCA done, and it was certainly not done in the clinical trials. FFR, IFR, rarely done because of the confusion when you have left ventricular hypertrophy, which often accompanies aortic stenosis. And certainly revascularization, it was always done at the discretion of the operator. So a little bit of subjectivity to it. What's interesting now is that while we are treating these patients at TAVR centers, many of them will follow up and have their continued coronary care at a non-TAVR center. So it's really important to have some guidance for treating coronary disease in transcatheter valve patients. What's interesting and what's been developed recently, Dr. Keffo from Milan proposed a strategy of not doing coronary angiography, of actually doing CTA for these patients. And what she found in her data was that only about 24% of patients needed to have coronary angiography after CTA. So that really, when routinely implemented, provided 37% less caths in this population, and there was no effect on long-term outcomes for this population. So it's definitely something to think about, particularly when contrast dye is of a concern, which is in many of these patients. And even if we're evaluating these patients in a more objective manner, and we do use FFR, the strategy only changes about 6% of the time. So really, we probably can do a CTA strategy and provide good information and not change the outcomes. There is certainly some data that when we start to do revascularization, that when we leave some lesions unrevascularized in complex multivessel disease, that there might be some negative impact. But you also have to remember that this was left to the discretion of the operators, and we don't know why they didn't revascularize. Was it because the lesions were super calcified, super diseased, very tortuous? Challenging lesions to do. And so there really hasn't been a randomized control trial done to help us delineate who should be treated and who should not be treated. One thing we do know is that when patients have their coronary disease done before they have their TAVR done, that there is a higher complication rate. Of course, you're going to be reaccessing the arteries. You're going to be putting them on some anticoagulation regimen. And so there are risks of routinely intervening. What's interesting is that after TAVR is done, there's a very low incidence of acute coronary syndrome in this population. In fact, it's only about 10% that has been seen in the registry data. And in this 10% of patients, we don't really know why they're at higher risk. Is it because of impaired flow dynamics and hypoperfusion because the prosthesis is in place? We also don't know if there's maybe subclinical leaflet thrombosis, which has been more recognized as an issue as we follow these TAVRs long term. In addition, you can have some late valve migration, which is pretty rare, but can certainly occur. And then it can impinge the coronary ostium. Lastly, there is a small group of patients who have Kunis syndrome, which is hypersensitivity to the metallic anions in the valve. And although it's very rare, we have to certainly think about it. So I think it's important to know that we don't have a lot of data to whether to treat or to not treat coronary disease before TAVR. But we know that when we do treat within 30 days, that there is a little bit of a higher risk of having a vascular complication, a little bit higher risk of 30-day mortality when it's done prior to TAVR. What we also know is that after TAVR, there's only about a 10% risk of acute coronary syndrome, even though 50% of the patients going into TAVR have coronary disease. So I think it's really time to do a clinical trial.